Okay. Good afternoon, everyone, and thank you for joining us today for this webinar we have scheduled called The Evolving Role of Endovascular Therapy in Treating Ischemic Stroke. We're very excited today to have Dr. Thanh Nguyen joining us and my colleague George Harston facilitating the discussion today as well. Just as a reminder, we would love for this to be an interactive session. So at the bottom of your screen, you'll see that there is a Q&A function. Please feel free to submit your questions as these discussions go forward. And at the end of the presentation, we will field some of your questions and hope to have some good interaction throughout this session today. So without further ado, I will hand it over to George.
Thank you very much, Jeff, and welcome everyone to this webinar. We're delighted to be hosting this webinar today because, as many of you know, at Brainomix, we're all about improving treatment of patients with stroke. And in the field of stroke, there's been nothing more transformative in the last few years than the advent of mechanical thrombectomy. It really has revolutionized the way that we deliver care and the way we organize care as well. So I'm absolutely delighted that we have a very distinguished speaker with us today to update us on the latest developments in the field. Dr. Thanh Nguyen is a collaborator and friend of ours, but also the director of interventional neurology and neuroradiology at Boston Medical Center. She's professor of neurology, neurosurgery, and radiology at Boston University School of Medicine, and she's also the president of the Society of Vascular and Interventional Neurology. So we're absolutely delighted that she's going to share her thoughts on thrombectomy with us. And so without further ado, I'll hand over to Thanh. Thank you very much.
Thank you, George. It's a great pleasure and honor to be here. Thank you, Jeff, for your help coordinating and initiating this series. I'm delighted to speak about the evolving role of endovascular therapy in the treatment of ischemic stroke on behalf of the Brainomix group. These are my disclosures. So for the outline for today, we will be covering several topics as you see listed below. And for introduction, as you know, and as you heard from George, thrombectomy has really revolutionized how we treat ischemic stroke. And much of this pinches on the initial data that we saw from the 2015 randomized trial showing very powerful treatment effect size with a number needed to treat as low as 3 to show a difference in disability at the 3-month outcomes. And if you compare this to other conditions we treat in medicine, you can just see how powerful thrombectomy is for stroke and reducing disability. It rivals defibrillation for VFib, permethrin for LICE, and sepsis early treatment. And if you look at what you do for percutaneous intervention for myocardial infarction, you can see that cardiologists also would salivate to have the kind of treatment effect that we're seeing with thrombectomy for a large vessel occlusion stroke. So part of the issue was that the initial trials were very successful in showing the benefit. It also raises the issues of how they were potentially restrictive in their eligibility criteria of enrolling patients so that they would show the best patients who could benefit from the treatment. And then the question arises is, what do you do for all other stroke patients who also need care, who don't fit the criteria by which patients were enrolled in the trials? And one of the examples by which we've noticed this disparity was in the late window patients presenting up to 24-hour window with the use of imaging selection in the DAWN trial, which, as you know, was the landmark trial for patients with large vessel occlusion up to 24 hours in the late window, 6 to 24, presenting with a large vessel occlusion and a significant baseline NI stroke scale deficit with criteria, as you see here, which no one is expected to memorize. They found a huge treatment effect in benefit of thrombectomy compared to control when looking at these patients at 90-day outcomes for a modified Rankin scale of 0 to 2. And then Diffuse 3 had to stop their trial when DAWN was presented. This was the 6 to 16-hour trial using advanced imaging with CT perfusion and rapid software to identify patients who could benefit from thrombectomy and showing these big mismatches and target mismatch profile to select patients. And again, they also showed very powerful treatment effect, 44% versus 60% in favor of thrombectomy for achieving functional independence at 90 days. And so the PI of the Diffuse 3 trial, Professor Greg Albers, wrote this very nice commentary in Stroke commenting on the late window paradox, showing huge treatment effects in the late window, even more than the early window, and stated that because access to acute MRI is limited, that CT perfusion will be required to select late window stroke patients for thrombectomy at most hospitals. And naturally, these recommendations and the criteria by which patients were enrolled in these trials trickled into the guidelines, into the AHA/ASA guidelines, soon to be updated in 2025. So we'll see how that pans out in terms of imaging selection. But as of 2019, this update did state that CT perfusion or diffusion-weighted imaging is recommended with level 1 evidence in patient selection for thrombectomy. And then the European Stroke Organization, the voice of stroke in Europe, stated in this guideline stating that in patients beyond 6 hours, advanced imaging selection is necessary with a strong recommendation. And so naturally, many centers followed suit and implemented advanced imaging as part of their workflow. And when I came across a patient who had a large vessel occlusion and who had a good-looking CAT scan in the late window, Jack told me, Jack was my stroke service director at the time. This was in 2020. He said that I would like a CT perfusion before we take this patient to angio. And this was a patient in an outside hospital. And I said to Jack, but Jack, the CT looks perfect. And Jack said, well, yeah, well, it's in the guidelines. And Jack was right. It's in the guidelines. And so I didn't have any leg to stand on to contest Jack that, I could just bypass the repeat imaging study. So that really motivated us to look at alternative ways that patients could be selected based on basic imaging as compared to advanced imaging in patients who have large vessel occlusion stroke. And so what we found in this late window study comparing patients present in the late window with large vessel occlusion, NI stroke scale of a 6 or greater, and also with large vessel occlusion of the anterior circulation. If you look at just overall data, you can see CTP patients seem slightly favored, and that was true in terms of the absolute benefit. But if you adjust for all the confounders, including age, the site of arterial occlusion, the baseline NIHSS, we really found that there was no difference in outcomes between those who were selected by basic non-contrast CT versus CT perfusion or MRI. And those in the CT group were just selected based on aspect score. We included 6 or greater. So just to show you that patients who went to CT selection alone were actually sicker, but when you adjust for it, there was no difference in outcomes between those selected versus advanced imaging modalities. And we also looked at the time metrics, meaning we looked at patients who presented directly to the endovascular center and who had time available stamps, and we found that there was faster door-to-puncture times in those who had a selection by non-con CT, with a savings of approximately 20 minutes compared to those who were selected by perfusion or MRI. And these were centers that were, a high volume and highly capable centers that we had in our center, so in our cohort. So even in patients who had access to advanced imaging, there were slower times to treatment if you had selection by perfusion or MRI compared to non-contrast CT scan. And so there was good commentary, good feedback that we received after this CLEAR study. Human Khosravani from Canada stated that this could help the field reconsider and perhaps pull back from reliance on advanced imaging, which was really the rage as of 2022, and to make endovascular therapy more accessible and care more equitable for patients who were impacted by large vessel occlusion stroke. And then the other feedback I received, which I didn't know at the time because you don't really know what happens in other parts of the world. A colleague in Ecuador in 2022 stated, we were just starting thrombectomy in Ecuador, 3 cases, all late, no advanced imaging justified because of the work and with good clinical results. So essentially, the goal is to try to reduce barriers to disability treatments that could help patients and not make the treatment accessible so difficult to take them to the angio suite to remove the clot out. And we recognize that guidelines being so important that we wrote our own guidelines as part of the Society of Vascular Interventional Neurology to state that in patients with proximal LVO 6 to 24 hours, that non-con CT can be used as the sole imaging modality to evaluate infarct size and to select your patients for thrombectomy. And then after this guideline, we also did more study on this area in this cohort study, finding that patients with large vessel occlusion who were matched to those who were treated medically in the late window 6 to 24 hours, that these patients actually had a twofold odds of better outcome with thrombectomy compared to standard medical care. And these were patients who straddled the time when they didn't have access to advanced imaging or before the Dawn and Diffuse 3 trial in this multi-center cohort study. Our work is further reinforced, before that, the hemorrhage rates, we have to report the safety. There was safety concerns with endovascular therapy, more hemorrhagic risk with endovascular therapy. However, mortality was higher in those who were medically managed. But overall, twofold odds of better outcome by ordinal MRS shift in patients selected for thrombectomy compared to leaving them with medical care. Our work is now reinforced by the Mr. Clean late randomized trial, which was published last year in the Lancet. This was what I call a BRAVE trial. They took patients who were not eligible for Dawn or Diffuse 3 because it would be unethical to randomize them to medical management, and everyone else who was not eligible for Dawn or Diffuse 3, but had these inclusion criteria being late window, ICA terminus, M1, M2 occlusion, selected by CAT scan, with the only exclusion criteria of CT showing more than 1/3 MCA territory hypodensity. And they also had to have some kind of collateral flow on the CTA. They found that in this study where patients were already selected out for those who were not certain to benefit, that they did see a benefit for thrombectomy compared to medical care in patients who had large vessel occlusion with an adjusted odds ratio of 1.7. So if you had any uncertainty or lack of confidence in your ability to make the call and say, okay, there's a large vessel occlusion, is there too much brain or not enough brain that's infarcted? You would be reassured by the large ischemic core trial data that have unraveled in the past 2 to 3 years via 6 large randomized trials. So the question is, how common is large ischemic core? And in fact, this was a study from Max Moken out of Buffalo, where he looked at the patients with aspects 0 to 5 in black versus aspects 6 to 8 in gray, and then good aspects 9 to 10 in white. And in the early window, very few patients actually had aspects 0 to 5. And then in the later time window, as you would expect, that you see more patients with large core because the infarct is maturing more. So this is just an interesting perspective on how common do you expect to see large ischemic core patients in your practice. So you can estimate 1 in 5 within a 24-hour window. And then the Hermes meta-analysis, which is the individual patient-level meta-analysis of patients from the early randomized trials, looked at patients based on aspects 0 to 4, and this was core lab adjudicated, and they found that those who had large ischemic core defined as aspects 0 to 4, you also see point estimates in favor of endovascular therapy. However, the sample size was very limited, only about 100 patients in this subgroup, and that is what propelled investigators to look at maybe we could expand indications to patients with large ischemic core, meaning aspects 5 or less. And so this is the subsequent wave of randomized trials that we just saw unravel this year and the past year as well. 6 randomized trial reporting on the role of endovascular therapy in patients with large ischemic core. So these are the countries in which patients were randomized. North America had a good representation with the SELECT-2 and TESLA randomized trials. LAST-A was mainly conducted in France as well as Spain. Tension led by our colleagues in Germany. Angel Aspect led by our colleagues in China, and then Rescue Japan in Japan. And so here is a table just to show you the overview of what were the patients that were entering these large core randomized trials. For the most part, it was the 24-hour window, except for tension, which went to 12 hours, and LAST, which went to 7 hours, because they thought these patients were fast progressors. And then the age as displayed. The NIH stroke scale, these patients for the most part all had significant neurological deficit. They all had pretty good baseline function with a low pre-stroke MRS, meaning very little disability prior to their stroke. And then the imaging selection criteria, across the board, everybody with an aspects 3 to 5 was included. Aspects 0 to 2 was permitted in last day trial, and then 2 to 5 in the Tesla trial, and then 0 to 2 in Angel aspect, but you had to also have this score as adjudicated by perfusion of 70 to 100 cc's to be included in the Angel aspect trial. And what's also notable in terms of the selection criteria is Tesla was mainly only selected by non-con CT, whereas last day was, for the most part, 86% selected by MRI, and tension more than 80% selected by non-con CT. So it matters just in terms of understanding how these trials showed benefit for patients with large ischemic core and how they were selected according to imaging modality and also clinical criteria. And so how do you define large core? It can be defined in two methods. And one is the Aspects Alberta Stroke Program Early CT score, which is a pretty standard and easy to use method to look at the area of ischemic change. As you see here, 10 defined regions of the cortex in the middle cerebral artery and also the subcortical regions. So it's a semi-quantitative scale. If you look at an MRI in a patient with large vessel occlusion, you will see a much lower aspects, meaning you will see more infarcts than you would on a CAT scan. So you would achieve a lower score on MRI than CT scan because MRI is so sensitive. Another way to look at large core is by volumetric methods, and that's perfusion imaging. So that's in general defined. Most trials use more than 70 cc's. One trial used 50 cc's or greater. And so this basically measures how much volume is of reduced blood flow. And classically for ischemic core, they're defining it as CBF of 30% or less. And so just to review aspects, again, these are the regions across the middle cerebral artery territory that we're adjudicating for loss of early ischemic changes. And just to show you in more magnified view, the 6 cortical regions, M1 to M6, and then the subcortical regions, caudate, lentiform nucleus, and then the internal capsule. Very difficult to pick up hypodensity in the internal capsule because it's already hypodense on the CT scan, but the other cortical regions, much higher yield, especially the insula and also the lentiform nucleus, high yield for looking for early ischemic changes. So the meta-analysis of the 6 randomized trials, this is study level meta-analysis published in the SVIN journal, showed that overall patients had improved ordinal shift analysis, meaning across the spectrum of the modified Rankin scale, you're seeing improvement of benefit with thrombectomy compared to medical care in those who had large ischemic core, and that odds is about 1.5 times improvement. However, if you look at dichotomized outcomes, meaning, okay, well, what's the chance of being independent with a large ischemic core? You can see that most patients are not independent with large ischemic core, and that's not surprising. 4 in 5 patients treated with thrombectomy will not achieve independence, whereas it's still better than medically managed patients, where only 1 in 10 achieve functional independence at 90 days. So as you can see, large ischemic core is a poor prognostic indicator, but it doesn't modify the treatment effect across the large core trials. And then also, if you look at the outcome of independent ambulation, which means MRS 0 to 3, which means they can walk independently without assistance of a person. So even if they were able to walk with a cane or walk with a walker, that still counts as MRS 0 to 3. You can see 1/3 will achieve independent ambulation, which is most likely a meaningful outcome and a worthwhile outcome, especially if you have large core, compared to 1 in 5 achieving independent ambulation at 90 days with large ischemic core. The biggest question we always worry about when we treat large core, and the reason there was hesitancy, is the worry about, oh, I'm going to cause symptomatic hemorrhage. And so what was surprising in the 6 randomized trials was how low the symptomatic hemorrhage risk was. It was on the order of 5.5% in the meta-analysis. But if you look at real world observational data on large ischemic core, the number is higher, and their reporting is 10% based on a meta-analysis we conducted for real-world symptomatic hemorrhage risk. So I wouldn't be too cavalier about saying, okay, your hemorrhage risk is going to be 5%. I would just probably try to relate it more to real world, because in real world, it's probably higher than what you see in the randomized trials, which could have a Hawthorne effect. The next question that is of high interest in large core is, does the size of the infarct matter? And that brings us to, the grading scale of aspects 0 to 2. And there were 4 trials that were collated in this study level meta-analysis, select 2, angel aspect, tension, and elastase. And note that only the trial that really targeted the aspect 0 to 2 was elastase, and most again were using MRI. And here across these 4 trials, they're seeing better odds of good outcome with aspect 0 to 2 with endovascular therapy compared to medical care. However, it's not the whole 6 trials that we have information on. And also, again, most of these results are driven by predominantly the elastase trial, which had a high number of patients with aspect 0 to 2, actually the highest number. And again, with selection of MRI, you can expect to find more patients who would have aspect 0 to 2. So when you look at the SELECT 2 trial, and if you look at ischemic core volume by perfusion, even with high core volumes of greater than 100 cc's and 150 cc's, we're still seeing point estimates in favor of thrombectomy with large core. The next question that is of interest is, does time to treatment matter? So a lot of these studies were 24 hours. Does that mean you can go to 24 hours? And so based on the forest plots of SELECT 2, it didn't matter whether patients were presenting within 12, 6 hours or 24 hours. You still see all these point estimates in favor of thrombectomy. So it didn't seem to matter in the SELECT 2 trial. Whereas in the angel aspect trial, this was just published literally 2 days ago, they did a time continuous analysis looking at the treatment effect of thrombectomy over time up to 24 hours. And they found that at around the 13-hour and a half mark that you could see loss of significance for benefit of thrombectomy with later time to treatment. So there is still a time dependence to treating patients with large core. So it doesn't mean that you can take your time and go up to 24 hours. In the Tesla randomized trial, which was all selection by non-con CT, what you can see is greater treatment effect size in the 0 to 6 hours with an absolute difference of 20% for patients with large core. And these are patients with aspects 2 to 5, whereas in the 6 to 24-hour window in Tesla, we're seeing the narrower treatment effect size. It's only about 6% treatment effect. So basically, again, suggesting there is a time dependence. So you want to treat these patients quickly because they're potentially rapid progressors. Another very interesting question has arisen from the large core studies, and that is the concept of the penumbra core mismatch concept. So traditionally, we're all here to salvage salvageable tissue, which is the penumbra, which is the area at risk for dying by reperfusion. And so there have been classic terms and definitions based on the SWIFT Prime and the Extend trials from 2015, looking at definitions for what is a mismatch. And so the mismatch is the difference or the ratio of the penumbra over the core volume that has been infarcted. And so ratios of 1.8 with a difference of 15 cc's in penumbra core volume have been postulated from the SWIFT Prime studies. And then in the Extend, they also use this definition of a ratio of penumbra to core of 1.2 times, and then the difference of core and penumbra volume of 10 cc's. And so both the angel aspect and the SELECT 2 trials had access to perfusion imaging to study this phenomenon. And what they did was they combined their data together and presented this at, I heard this at the Beijing conference, where they looked at the lack of mismatch. You don't have this mismatched profile, and they still saw overall benefit of thrombectomy across approximately 100 patients studied in these 2 cohorts. So still without the presence of classic mismatch signature, as you would expect on perfusion, you're still seeing in this subgroup analysis a benefit of thrombectomy. And this is all post hoc, obviously. So obviously, there are many aspects to look into with large ischemic core. Are you looking at the gray-white differentiation? How are your window level settings when you think about, is this dark or not? What is the role of edema, and how dark should the ischemia be? So if you look at this series of CAT scans, you can see, the first on your left, very dark, very easy to see the hypodensity. Was here not as dark, but it's still dark and visible to the eye, and then here you can barely perceive it, and here it is essentially normal. So there are many shades of dark to consider when you think about to what degree does the hypodensity help you make a decision? And so this was also looked at in the SELECT-2 trial, where they did a subgroup analysis and they manually delineated the hypodensity areas on the CAT scans. And then they found the median Hounsfield units of these regions that were hypodense after manual delineation. And then they found that the median fifth percentile was 26 Hounsfield units. So they used that as a cutoff and then measured if patients had more of this Hounsfield units hypodensity defined as lower than 26 Hounsfield units, then they had less likelihood of benefit. So basically the bottom line from their study led by Vignan Yogendrakumar in Australia at the time and now in Canada found that there was no significant benefit of thrombectomy in patients with increasing volume of severe hypodensity on CAT scan. So that could be potentially a marker of saying, okay, there may be no benefit for these patients. And then those who had substantial volumes of severe hypodensity had more cerebral edema and higher need for hemicraniectomy after a thrombectomy. We were also interested in the question of unsuccessful recanalization. So you have a large cohort patient, not everybody gets recanalized, maybe 10 to 20%. And so in the angel aspect, it was about, I think 20% were unsuccessful in recanalization. What happens to these patients? So we compared those who were unsuccessfully recanalized. There were only 43 in the angel aspect because so many had successful recanalization. And then we compared to those who were medically managed. And what we found was that for the outcome of very poor outcome, meaning MRS 5 or 6, that essentially was pretty similar between the two arms. However, what we noticed was obviously you would have more hemorrhage, any intracranial hemorrhage with unsuccessful EBT, and the infarct volume growth, very interestingly, does grow with endovascular therapy if you're not successful in opening up the artery. So the growth was 142 cc's compared to 90 cc's, and the use of craniectomy was also higher in those who had unsuccessful thrombectomy. Here's an example of a patient, 48-year-old man who collapsed at work, and we marked his aspects here as 5 or no greater. Based on the stars, you see this hypodense early ischemic changes. And so this was a right terminus carotid occlusion, and the patient also had a aortic dissection. He was known to have that in his history. So we went transradial to scoop out the terminus carotid occlusion on the right and achieved full reperfusion. We weren't sure how he was going to do because we knew that he came in with a large ischemic core, and this was the MRI on follow-ups, which is a moderately sized infarct. And I was surprised to see him on, stroke day 2 having anti-gravity of his arm and leg, and then eventually ambulating at the 90-day follow-up. And I was wondering, how is this possible with such a largish core? And I went back to look at the MRI, and what you notice is that the motor cortex here is spared. And so that could explain that the eloquence also plays a huge role in these patients with large ischemic core. And sometimes you're lucky and can achieve really good outcomes for these patients. Another realm that is of interest in the thrombectomy world now is the role of bridging. Should you give thrombolysis before thrombectomy versus going directly to the angio suite? And so there were several randomized trials to this effect. In fact, 6 of them combined into the IRIS meta-analysis. And what they found was that in those who had bridging thrombolysis prior to thrombectomy, that successful reperfusion was higher, and that essentially direct thrombectomy was non-inferior to bridging for less severe but not more stringent non-inferiority margins. And what's really interesting that came out of this IRIS meta-analysis from this past year is that they looked at the time dependence of the use of thrombolytics prior to thrombectomy, and they found that before this time cutoff of 2 hours and 15 minutes, you do see superiority of giving the thrombolytic prior to thrombectomy compared to thrombectomy alone. But after this 2 hours and 15 time mark, they could not establish that giving thrombolytics prior to thrombectomy was superior. And the caveat in all of this is that these are patients who presented directly to an endovascular center. So obviously, if you're treating patients who are at outside hospitals with no endovascular capability. You have to treat them if they're eligible within the time window and the imaging paradigms that you have already in your protocols. And in these patients who arrive directly to the endovascular center, the conclusions and the interpretations from most of these trials was that, well, you should still give the lytic even up to the standard 4.5-hour window. And that was felt because that there's always potential treatment delays, and that some of these early window trials where they were giving bridging thrombolysis, that the bridging arm may have been harmed by the fact that there was delay to giving the lytics because patients were getting randomized to the trials. So this brings us to another hot topic, which is tandem occlusion. So tandem occlusion occurs in maybe 15% of patients. This is an example of a patient who had a tandem occlusion. And the issue with tandems is that it's a bit more acrobatic to do the thrombectomy because you have to address both the neck lesion and the intracranial lesion. So sometimes you have to do angioplasty, as you see here, and deploy a stent, and then just monitor to make sure there's no reocclusion. And some of these clots can be really long to retrieve. And so the question now is, should you stent acutely or not? That has not been well addressed in the randomized trials because many of these tandem lesions were excluded. And so it's the subject now of an ongoing randomized trial. Proud to be participant in the Picasso randomized trials. It's one of 5 randomized trials ongoing in the world to try to get you a better answer. Is it better to stent acutely or defer revascularization of the carotid to a later time period? ICAD LVO is another hot topic and a hot arena in our field because we can see that these lesions in about 10% of patients. And the classic signs on angiographic imaging is this truncal type occlusion. You can see how it tapers here, suggestive of an underlying ICAD lesion. And also when you place the stent retriever, you can see how there's a watermelon seeding effect where there is a watermelon seed at the site of the stenosis, as you see here also with the stent. So what's new in ICAD LVO, it's been an actively evolving field, which is really exciting for us because we have better understanding of how to optimize these patients because they are tricky. And what we found in the rescue BT trial, which was led in China, was they were giving tirofiban prior to thrombectomy in a randomized fashion in the rescue BT trial. And what they found overall in the trial, it was neutral. It didn't confer any benefit to give drugs prior to thrombectomy, but in patients who had the ICAD LVO subgroup from the TOAST criteria, they found there was a significant benefit from giving tirofiban with also fewer passes that they had to conduct if tirofiban was on board. So it just shows you how powerful adjunctive drugs could be in certain subgroups of patients who could benefit it if the lesion is atherosclerotic in nature. And so it was so of such a high interest that the investigators also conducted a comparison of, preceding drugs prior to your thrombectomy and compared the DEVT trial, which was the bridging trial, versus the rescue BT trial, and found these really good outcomes in those who were treated with tirofiban. Of course, this is post hoc analysis, but just shows you that, maybe alteplase is not the answer for everybody prior to thrombectomy. This also leads us to another interesting realm of ICAD LVO, and that's the Angel Reboot trial, which was led by our colleagues in Beijing. This was a trial looking at patients who had ICAD LVO, who were randomized, who had residual stenosis after thrombectomy. So they had 70% stenosis, which is considered a population at high risk of reocclusion. So 2/3 of patients in Angel Reboot were randomized with residual stenosis that was severe after thrombectomy. And then another 1/3 was randomized if they had failed recanalization, meaning TICI 0 to 2A. And so in this randomized trial, which is the first of its kind for these patients with ICAD LVO, they found that the use of bailout intracranial angioplasty or stenting, or BAOS, wasn't associated with any improvement in outcomes compared to just standard therapy, which is continuing your thrombectomy until you're done. And what's unique about this trial and why we think it's neutral is because of the following reasons. One is the peri-procedural use of tirofiban was really high in both arms. So they were allowed to use tirofiban if you were in control or in the intervention group. And so it does make you wonder, does just the drug itself, is that enough to, have successful reperfusion and potentially outcomes down the road? And also the patients in this trial, for the most part, were underlying ICAD. And so the other issue that I wanted to explain to you for Angel Reboot is that the reperfusion success was extremely high. Both arms had 90% reperfusion success, which is potentially another reason why it was a neutral trial, but still gives you a lot of information about how well these patients can do with adjunctive treatments. We move into the realm of medium and distal vessel occlusion, which is another hot topic, and especially for 2025, 2 randomized trials will be reporting at the ISC. So what is a medium vessel occlusion? And that essentially is a vessel that is distal to the proximal vessels, as you see colored here. The M2 non-dominant is classically considered a medium vessel occlusion. And then the M3, M4 branches, A1 and A2. And then in the posterior cerebral artery, P1 going up to the PCOM origin, and then the P2 around the midbrain, and then the P3, P4 calcarine branches. So the other accompanying definitions for MEVO is that you would see a clinical deficit, but however, these deficits are obviously less severe than that you would see with LVO because they're more distal occlusions, and the vessel size for MEVOs are 0.75 to 2 millimeters. How common are medium or distal vessel occlusions? The Dijon Stroke Registry looked at this and had a nice study about the frequency of arterial occlusions and found that 1 in 3 patients will have a visible occlusion that's medium or distal. The issue with these distal occlusions is that they're in distal territory, they're more risky. You can see the tortuosity in red here that we would have to traverse to open up these arteries. So the more distal they are, the smaller they are, the thinner are their walls, and the more tortuosity we have to negotiate. This is a patient that I included in the ESCAPE MEVO trial. And so it's a randomized trial. And so we were able to get, pretty successful recanalization after 1 pass, a straightforward M2 occlusion with just a stent retriever. And then you can see it's a TICI-3 result, but then afterwards, the patient still had a hemorrhage, a subarachnoid hemorrhage, but despite that, very low volumes of infarct and still did quite well on discharge. So it doesn't say that, this has doesn't say anything about the outcomes, but just to show you that we do have some challenges that we need to face in treating these patients with distal vessel occlusions. And this is a video to show you a stent retriever in a cadaver model and the hemorrhage that can occur with traction on the artery when it's in a distal territory. And this is also illustrated by Marios's article in Clinical Neuroradiology, showing these perforators which have shearing forces that can rupture just with distal retrieval. And in cadaver models, because we don't always see this on angio so well, you can see these rich perforators from these M2 segments that you have to be cognizant of as you treat these patients. While we're on cadavers, I just wanted to show you that another reason for ineffective thrombectomy is when you place an aspiration catheter, you can have, if it's not at the face of the clot, then the artery can collapse and you can have unsuccessful thrombectomy. So just knowing where your position is and trying to be right at the face of the clot is key to having successful reperfusion. In the Plato study, which was a MEVO study for posterior cerebral artery occlusion, we did not see a benefit for the outcome of 90-day MRS shift, which was our primary outcome. But for other secondary endpoints, we did see benefit with thrombectomy compared to medical care. However, this was also at the expense of higher rates of symptomatic hemorrhage and 90-day mortality. So it remains to be seen whether we can see a benefit for patients with medium vessel occlusions with thrombectomy. I think this is an important study that we did secondarily from the Plato study, which is the PCA occlusions. And what we did was we looked at NIH stroke scale as a continuous variable, and we found that at a cutoff NIH stroke scale of 6 or greater, that was when we saw more favorable outcomes with thrombectomy compared to medical care, despite having higher risks of mortality and symptomatic hemorrhage. So it is possible that your baseline NIH stroke scale will be a modifier of explaining potential benefit for thrombectomy in these MEVO patients. And so just to show you an example of a MEVO case, my partner, Mohammed Abdelkader, he's an ace in finding all these MEVO occlusions. There's a lot of talk about using perfusion to identify it, but he picks up everything. And so he even picks up fetal PCA, which is rare. It's about 1% of your cases. But if you look hard enough, you can see this hyperdense sign on the lateral sagittal. And then you can see on the reconstructions that there's M1 and a fetal PCA occlusion. And so these patients you can revascularize, but they don't always do well because of the lack of collaterals if there's an also concomitant M1 occlusion. So several MEVO trials are finished or wrapping up in terms of their enrollment. And so here's just a table to show you the wide variety of patients that we're studying. What are their territory occlusions? What are their baseline NI stroke scale that they're entering into the trials with? What kind of devices are we using? And what is the primary endpoint? Because that could potentially make or break a trial in terms of its primary endpoint. We move on to the issue of no reflow phenomenon, which is a very hot topic in the past 2 years. It started actually in the 1940s or 1950s with Ames, where he studied in these tissue models looking at the issue of no reflow. So this is a normal capillary reflow, whereas in this case, where you have revascularization of an occlusion and you don't see any reflow at the capillary territory. So this was studied by Angel Chamorro in the CHOICE study. This is a phase 2 trial, only 120 patients or so, and showing huge treatment effect with intra-arterial alteplase compared to placebo after successful thrombectomy. So there are about more than 7 randomized trials ongoing or completed in this domain. One has been reported publicly, Attention IA, that was a neutral trial, and then 2 will be published in January, and 3 of them will be presented at the ISC at least. So we will have more data to inform you if it's worth giving IA lytics after partial or successful thrombectomy. Low NIHSS LVO is another area that is still uncertain. We're not seeing a benefit here in this meta-analysis by our colleagues in Greece. And if you look at the randomized trials, the Endolo randomized trial has held enrollment for Endolo, and they're going to merge with the STEP platform in the United States. So we still have yet to answer to you if it is worth chasing these with thrombectomy. And the MOST trial has done really well, having enrolled at least 610 patients since they started in 2019. And so they're close to finishing, but we will have hopefully more data to share with you whether patients with low NIHSS LVO should be chased with thrombectomy or left with medical care. And supporting this, we are doing a large international cohort study called TRIMIS. Currently, we have more than 3,000 patients included from this cohort study. And so we hope to have a better idea of how we should treat these patients optimally with low NIHSS and arterial occlusion. So just to summarize, these are some of the gaps in knowledge that we discuss in terms of the large stroke burden, patients with mild stroke, distal occlusions, acute carotid stenting, and then also greater than 24-hour window. I'm happy to refer you to a paper that we worked on, a review paper for the Lancet, which I think it might have triggered this seminar, so thank you for that. So in conclusion, EVT is the most effective treatment for patients with acute stroke and a persisting large artery occlusion up to the 24-hour window. And I'm also going to summarize, at least for the large core, because it's obviously the meat of the last 3 years. Large core predicts lower likelihood of doing well with thrombectomy, but doesn't modify the treatment effect. Earlier treatment is associated with greater likelihood of benefit than later treatment, so it is time dependent. Patients with aspect 0 to 2, according to non-contrast CT, I would still argue that there is uncertainty in terms of its benefit based on current data. And even if there's no perfusion mismatch seen, at least in the large core literature, we're seeing a benefit of thrombectomy based on post hoc analyses. And then the greater the volume of severity of hypodensity on the CAT scan, the lower the likelihood you're going to benefit from thrombectomy. And so all to say that a simplified imaging protocol using non-con CT, CTA is feasible for thrombectomy in light of the large core data and also the Mr. Clean Late trial data. So with that, I'm happy to wrap it up with any questions you may have, and just share this Elvo-Mevo cartoon by my former fellow Hisham Masood.
Thank you, Tan. That was a fantastic overview, a tour de force really of the big questions in the field and more recent advances. It was a really helpful context, I thought, and framing that you gave, particularly with regards to the clinical trials, how these were framed, why they were designed as they are, and then how the field has developed and the evidence evolved. And congratulations on all the work that you've done to contribute to that journey. While we wait for some questions, perhaps I'll just ask a couple of questions if I might take that prerogative. I was really interested in the case of the large core, that gentleman who with a follow-up MRI looked sort of modestly big, but looked like he did clinically very well. And you directly referenced eloquence and thinking about his motor strip being spared. But he also looked like one of the younger patients, perhaps, that in the distribution that come in to be treated. And I wondered what your thoughts are on how age and premorbid frailty interacts, if at all, with the treatment effect of thrombectomy.
Yeah, outstanding question, George. So we don't have a lot of data in randomized trials of patients who have more frailty because they have, for the most part, been excluded. And the reason for that is because the outcomes that are being used are pretty narrow. They're using patients who are looking healthy without any disability. So if you already have disability, then how can you get any better than if you already had disability to start with? So there are a lot of observational data looking at pre-stroke disability. Frailty, I don't have as great handle on that because we just go by the pre-stroke MRS. And so at least for pre-stroke disability, your goal is to get back to your baseline disability. And if you can get that, that's a home run for the patient. Because if you think about it, I was faced with this patient who was an amputee, right? So he had no leg to stand on, and then he had arm plegia. And then I said, well, if I don't go after the arm, he's going to be more disabled because he's already lost, one limb. So it just means that, I felt more compelled to fight for him because I knew he was going to lose more if I didn't go after it. So that's how I think about pre-stroke disability. There's no reason why to exclude them other than, they're just not in the guidelines, but it doesn't mean they shouldn't be included. And so based on observational data, to answer your question, if they return to their pre-stroke disability level, we are seeing that occurring with thrombectomy. So we're seeing positive response in that regard. And so there is a treatment benefit even in patients with pre-stroke disability. For frailty, it depends on what scales you're using. So that hasn't been completely hashed out, but I imagine it's crosses over territory with pre-stroke disability scales as well.
That's a really interesting point. And I suppose more broadly, there are patients who fall outside the enrollment criteria for their clinical trials and the evidence base. But the treatment effect is very compelling, for these proximal, these M1 occlusions, for example. On a practical basis, are there any M1s that you don't treat in terms of translating the evidence to clinical practice, and who might they be?
Yeah, this outstanding question. So I do pause for the low NIHSS LVO patients, especially if I think, okay, maybe they have ICAD to explain their symptom, or they come just with dysarthria and a facial droop. Am I really going to chase after that LVO? So I tend to be a little bit more conservative about them. I've had, not just M1, but even Basler's where I chased and it was an ICAD-like lesion. And then it was, very difficult to open up and the patient ended up being worse. So those patients, I tend to be a bit more conservative because I'm just worried about making them worse. So we'll put them in the ICU. And if they deteriorate, then I feel much better about going after the lesion because it's supported by all the randomized trial data you're seeing. Whereas some of these patients who come in with, looking good and mild, they can do pretty well. And I've been quite impressed on their outcomes because I do follow them. So another key message of this talk is, you want to follow up your patients. You want to see how they do, because that gives you feedback on, did you make the right decision on what you did in the first place? So even though yes, I'm an interventionalist, but I still follow those that I medically manage because I always want to know, did I make the right call or not?
Brilliant. Thank you, Thanh. There's a couple of questions on a similar theme from the audience, and they're about the translation of evidence into clinical practice. And clearly, practice is still very varied. Not everyone follows the same approaches. And I wondered if you had any thoughts on how we, in light of these questions, how we drive the translation of the new evidence into clinical practice and drive the sort of optimization of delivery of mechanical thrombectomy.
Yeah, outstanding question. That's so variable based on the region you live, the infrastructure, and the government support of thrombectomy services. In the UK, I think you've had a big win recently where now thrombectomy is supported for care in terms of the personnel to take care at night so that you have it all days, all day and night, not just daytime. So just the advocacy, I think, is really important, and SVIN is playing a big role in that, and so are many other societal organizations in terms of going to governments, going to policymakers to advocate for the funding and the resourcing of mechanical thrombectomy, and also trying to think, how do I, get labs to work, and how do I get the EMS to come to my hospital, because in many regions of the world, the pre-stroke education is lacking, and the channels to get from first medical contact to the hospital is tremendously full of obstacle courses. So there are huge delays in many parts of the world. So we have lots to do in terms of educating just so that patients get to the lab. And it's not just thrombectomy. You have to build the whole stroke systems of care because obviously many patients can have hemorrhages and other mild strokes that don't need thrombectomy. So you want to build up the whole multidisciplinary team from ICU to ward to the recovery units to make sure that patients get the spectrum of care they need for everything you're going to offer them.
So thank you, Tan. That's really helpful. I suppose on that theme, but maybe more directed, selfishly for us as a company, Brainomix, we're very obviously we do imaging and AI imaging support. What's your sort of ask to us? What's your steer? Where should we focus in terms of trying to improve access to treatment for patients going forward?
Yeah, that's brilliant, George. So AI has played a big role in improving times to treatment. There are many studies, including from Brainomix and many other AI companies, showing that the automatic detection and call of these LVOs and just telling you, how much salvageable or how much brain is affected can really inform the decision making so that clinicians can just at the one button can just activate a team and then you're all there. I've seen both systems. I've seen a system where we don't have the automated software, and there are significant delays, especially at primary stroke centers, where they don't have the full team to take care of every stroke code. And so those delays can be 1 to 2 hours of lost time to reperfusion. So I think in these centers where the teams are not as well oiled, this is where the role of automatic software and imaging can really help to facilitate care, because obviously time is brain. Even in advanced stroke centers, they are very happy and very keen to continue to use automated software, because even then they do have more faster times to treatment, even with the automatic software. So there's a huge role to be said for that in terms of helping gain access. And in the US, I think there's a reimbursement code now that allows centers to reimburse for this automated detection technology.
Perfect. That's really really helpful. Thank you. I suppose more broadly, one of the other areas we're interested in is thinking about not just existing treatments like thrombectomy, but the sort of next generation of treatments, what stroke care is going to be like in 10, 20, 30 years time. And I wondered what your thoughts are on the sort of the next drug frontiers, perhaps. I mean, there's a whole really impressive raft of innovations and devices, but from a whether you talked on sort of adjunctive lytic therapy. Where would you put your money? Where do you think pharma companies should focus? Is it around lytics, reperfusion, or is it neuroprotection or mitigating secondary injury? What do you think is going to be the next frontier in the pharmacology world?
Yeah, outstanding question, George. You got me there. So the neuroprotection has been tricky because neranotide was all the rage, and we were all banking on neranotide being, the holy grail for ischemic stroke. And unfortunately, it didn't pan out, even after, they took the subgroup that had no thrombolytic on board and studied them and really found no benefit. So it makes you wonder, are you seeing a ceiling effect with thrombectomy, after which you just can't get better outcomes because, the control group is doing so well. Of course, I think the opportunity lies in patients with large core, and these patients are still being excluded from a lot of these neuroprotection studies I'm seeing because they think, oh, they're not going to do well, but they have the most to gain from your drug. So I think there's an opportunity now for large core, and we're seeing that signal in the Marvel randomized trials using steroids. Overall trial negative, but in the patients, it's coming out with proximal occlusions. You're seeing some benefit on the secondary outcomes. So even though your primary outcome is negative, I think a lot of the insights and a lot of the ideas can develop just from those secondary endpoints, because it gives you signals on figuring where should I look at a meaningful endpoint for my next clinical trial. So steroids, a potential role for large core. Thrombolytics after successful thrombectomy, still a hot topic, but choosing them and refining them is still an area of active research. Do you do more imaging to find out those who are not going to reflow? So those are all big questions. And back to your question, where would I put my money? It's multi-directional, right? So there are multiple facets and multiple areas of the ischemic cascade that you would want to target. So a drug that would target all those, I think, is the holy grail.
Thank you, Tan. It's really, really insightful. I suppose maybe the last that we've got a few minutes left, and I just had the other sort of burning question I've got is I was really excited by the trials you described, looking at sort of medium and distal vessel occlusions and the data that's going to be coming hopefully very soon. I was thinking about how we interpret these trials, not knowing what the results are going to be, but do you think all MEVOs are the same, and how do you think the results will, answer or not the question about sort of medium vessel occlusions?
Yeah. So I'm under embargo. Like I'm not allowed to speak
Indeed.
on the trials. But if the trial is positive, I think it will drive, doing more thrombectomy for these patients, because, we're really chasing a reduction of disability. So most of these trials, their endpoints is to reduce disability. They're not really targeting patients with non-disabling stroke. So if we can reduce disability, then I think, we're going to be treating more patients. But of course, we have to still look at the issues of hemorrhage, because it's still an issue, maybe a bigger issue with MEVO than LVO. LVO, the hemorrhage doesn't seem to be as an impact as MEVO, because these patients already look bad, right? Whereas MEVO, they don't look as bad, and you give them a hemorrhage, they're going to look worse. So it's a consideration we all have to be careful about. We don't necessarily want to chase those who have non-disabling deficits, because you can seriously cause harm. You saw the hemorrhage that I created in that one patient with the MEVO, right? And if just bad luck, you could get more hemorrhage than I actually got. So non-disabling deficit, I might be a bit cautious. The holy grail, I think, is maybe these devices we're using are not the panacea. Maybe there's something else we could do, like a drug or these nanoparticles. I didn't mention it, but there are these particles that you can inject that kind of agitate the clot. And the hope is that it doesn't cause this hemorrhage risk that we're seeing with traction with devices on these distal occlusions. So I think it's still an active area of research, and I don't think we have the answer yet. And how it changes the field will obviously depend on the results we're seeing from the trials, and also whether they got IVT prior to the thrombectomy will make a big difference in determining outcomes, because the guess is those who got IVT, may do well in the control arm, right? Because these arteries can open. And so, are we going to see any difference in those who got IVT versus no IVT? So I think, those subgroups will be really interesting to really understand the nuances of how do we treat MEVOs better.
Good. Thank you very much, Tan. I'm aware we're getting to the top of the hour and the end of the time we've got available. I feel like we could talk about this all day. It's been really fascinating insight, and thank you so much for your time and sharing your thoughts about where the field is and where it's going next. It's been not only insightful, but it's also been really entertaining as well. I think it was a fantastic overview of the field. So thank you very much on behalf of us all. And with that, I'll pass back to Jeff to close. But yeah, thanks again.
Thanks, George. And thank you, Tan. Only to echo George's comments, that was outstanding and really informative, and I think people will have found that to be excellent. So thank you everyone also for dialing in and joining us this afternoon. Continue to follow us as we have future webinars planned for 2025, and we will also be sharing the recording of this afterwards too, in case you want to have a rewatch. But thank you again, Tan, and thank you, George, and have a good rest of the day, everyone.
Thank you, George and Jeff. It was a great pleasure.
Thank you very much. Bye-bye.
Bye.